Good day and welcome to the webinar. Today's topic is hearing loss and dementia in older adults, and we thank you for joining us today. These complimentary webinars are brought to you through a collaboration of sponsorship with O'Connor Mortuary, Care Choices, Hospice and Palliative Services, Caring Companions at Home, and Alzheimer's Orange County. And my name is Kim Bailey, and I'm a gerontologist here at Alzheimer's Orange County, and I will be your host today. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial to anyone who cares for and works with older adults. We hope that you find today's presentation especially informative and useful. And our presenter is going to be Dr. Allison Huang. Before I introduce her and tell you all about her, I'll review what you need to know if you're interested in earning CE credit for today's webinar. So you must be online for 60 minutes, meaning that you must have logged in at the start of the webinar. You must have access to both audio and visual components on your computer. If you want CE credit, don't share your link with others. This is your unique record of attendance. If you do share your link or use another attendee's link, you will not receive CE credit, unfortunately. There are a series of poll questions. Please answer those questions immediately. This is proof of your active attendance. If for any reason you have difficulty accessing or answering the poll questions, please type your response in the chat box so that we know that you're actively attending and you will get credit in that way. Please also continue or complete the survey immediately as we exit the webinar. We will also send a link out by email if you do not complete the survey when exiting the webinar. And this, of course, is all necessary for you to receive your certificate of completion. Basics for everybody are your mics and videos are automatically disabled. That doesn't mean you're not able to ask questions of our wonderful speaker. You can do that by entering your questions into the chat, and then we've reserved time at the end of the presentation to have that Q&A with our speaker. So next, let me tell you a little bit about our speaker. We're thrilled to have her. She is Allison Huang, and she's a senior research associate in the Johns Hopkins Bloomberg School of Public Health Department of Epidemiology. Dr. Huang is trained on the epidemiology of aging and studies the impact of sensory loss on cognitive and mental health in older adults. She has a specific interest in sensory loss, social isolation, and loneliness. In her role as core faculty member at the Cochlear Center for Hearing and Public Health, Dr. Huang oversees scientific analyses and the development of manuscripts utilizing data from the Aging and Cognitive Health Evaluation in Elders, also known as ACHIEVE randomized trial, as well as the associated arthroscoliosis, I'm so sorry, I mispronounced that, risk in communities neurocognitive study. Huang holds a PhD in mental health and a master's in public health from Johns Hopkins Bloomberg School of Public Health. And it's now with great pleasure that I introduce you to our esteemed speaker today, Dr. Allison Huang.
Thank you so much for that introduction and invitation to speak with you all today. I'm really looking forward to talking about this topic and hearing about the work that you all do in this group as well. So, as stated, we'll be talking today about hearing loss and dementia in older adults. Quick outline. So we'll start with hearing loss and dementia background, as well as some general definitions and principles. I'll then talk about the results from the ACHIEVE randomized control trial. This is new as of just within the year. So this is kind of what's new and exciting in the hearing research world right now. And then I'll close with some of our future work on hearing health awareness and some of the future directions for the research. So I'm sure it's well known to this group that the US population is aging, and we're actually at an important inflection point in that soon, within the next 10 years, we'll actually have more adults over 65 years than younger adults under 18 years in the United States. And with that rising number of older adults in the population, we also see a rise in the number of conditions that affect older adults specifically, such as dementia. So in parallel, we're also seeing this rise in the number of dementia cases over the next couple decades, so much so that by 2060, we could see nearly 14 million cases of dementia. And that leads to some critical public health questions. So right now, there are treatments for dementia that have been released and FDA approved recently, but these treatments are pharmacologic, and they do have some strong safety concerns, as well as limited effectiveness, as well as cost concerns. The cost is very high, which really limits accessibility for all older adults who may benefit from treatment. So really, the focus is on public health, and that focus is really geared towards prevention and risk reduction of dementia in light of pharmacologic treatments that really aren't the most effective or safe or accessible at the moment. So that leads to a couple critical public health questions. So one are, what are the modifiable risk factors for dementia? In terms of what could we intervene on, what could we modify to reduce risk? What are the mechanistic pathways between these risk factors in dementia? And what interventions can modify the mechanistic pathways to reduce risk of dementia? So we'll start with the first one. What are the modifiable risk factors for dementia? And this is a really nice figure from the Lancet. This is the Lancet Commission on Dementia Prevention, Intervention, and Care. And they did a review in 2020 and published 12 modifiable risk factors for dementia that had the strongest evidence linking with a connection with dementia. And this figure shows all 12, and they occur throughout the life course. We've got early life risk factors like less education, midlife risk factors, as well as late life. And some of these risk factors are easier to intervene on than others. You can imagine, someone in late life, it's impossible to intervene on education status in early life. And I'll call your attention to hearing loss. Hearing loss is actually the strongest of the 12 modifiable risk factors for dementia. And it's listed here as midlife, but it's really a midlife or a late life risk factor. And that 8% in that bubble there represents the population attributable fraction. So that means assuming a causal relationship between hearing loss and dementia, if we were to eliminate hearing loss as a risk factor, we could actually reduce the number of cases of dementia by 8%, which is really impactful given the high prevalence of dementia. And just like dementia, hearing loss is also quite common and quite prevalent in older adults. Prevalence of hearing loss increases with age, and we go from 1 in 10 in those 50 to 59 to about half of older adults in those 70 to 79, and about 8 in 10 in those over 80. So here, the prevalence of just any prevalence of any hearing loss increases with age, but also there's greater severity in older age as well. So just like dementia, there are a large number of people who have hearing loss as well. And hearing depends on a couple things. So it depends on both peripheral auditory encoding and central auditory decoding. So if you look at this first box, so this is actually sound. So sound has intensity, which are the spikes here. It also has a frequency, and it also has a duration. So this is kind of a nice figure of what sound looks like. And that sound goes through the ear. And then at the back of the cochlea in the outer ear, this is where there's the ear actually just recognizes there's sound. It travels through the outer ear and it's encoded there. And then it transmits a signal to the auditory cortex in the brain, where central auditory processing takes place. So that's the decoding part. So that's actually more of a higher level process where the brain gets involved to help decode the sound and try to decipher what the sound is or means. So if it's speech, it can help decipher, what the speech means or what this person is saying. It deciphers it into something more meaningful. And audiologists sometimes refer to these two systems as hearing, which is the outer ear encoding part of just hearing a sound, versus listening, which is more of the central auditory processing part of decoding. There are many types of hearing loss, but the hearing loss I focus on in my research is age-related hearing loss. And that really just happens naturally with age. It's a normal part of aging. It really happens to everyone. There are factors like noise exposure and things similar that could make hearing loss come quicker or make it more severe. But in general, hearing loss is a normal part of aging. It does happen to everybody. This time, I believe it is time for our first poll.
Okay, so our question is, hearing depends on encoding and decoding. Is that statement true or false? Everyone quickly go ahead and submit your answer so that we can get back to our presentation. Again, hearing depends on encoding and decoding. True or false? Okay, I think everybody's had a chance to weigh in. If you have any trouble, put the answer in the chat box. And it looks like pretty much everybody got that right, so that's great. And back to you, Dr. Huang.
Great job. So for age-related hearing loss, as mentioned, this does result from multiple etiologic processes that can progressively damage the cochlea. And hearing, just that, whether you can hear a sound or not, is usually measured by pure tone average. It's the most common measurement of hearing at several frequencies, most important for speech understanding. And today we're focusing on cognition, dementia, and brain health, but I want to highlight as well that hearing loss does affect multiple components of health and healthy aging. So of course we have this connection with dementia, but there is also a strong connection between hearing loss and social engagement and mental health. And given my training in mental health, this is kind of where a lot of my interests lie, as well as the connection between hearing loss and mental health. Hearing loss also has an impact on physical activity, physical function, as well as healthcare utilization. So looking at the link between hearing loss and dementia, this side figure on the right is also taken from the same report that this nice, beautiful figure is taken from. And these are the results of a literature review and meta-analysis that the Lancet Commission conducted. And they did a review of the literature to find the highest quality studies looking at the connection between hearing loss and dementia. And they had strict criteria that the studies had to have an objective measure of hearing. So it had to be measured by pure tone average, not just self-reported. It had to be a longitudinal study measuring dementia over time, and also adjust for a number of confounders. And they identified 3 studies, and doing the meta-analysis, they actually found that together, these studies suggest that hearing loss is associated with 1.94 times greater risk of dementia over time. And you can see that's in that bolded random effects model line, that 1.94. So we're seeing actually that hearing loss is associated with a nearly 2 times higher risk of dementia. Hearing loss is also related to cognition. So this is a forest plot from another literature review looking at a number of studies that looked at hearing loss and different aspects of cognition. And you can see on this forest plot that we have the null value at 0, the left side are values that indicate a decline in each cognitive ability. The right side indicates an improvement, and you can see all the way on the left, many different types of cognitive ability, from attention to memory to processing speed. And we can see, and the size of the box indicates the strength of the evidence. And you can see pretty consistently across these multiple domains of cognition that hearing loss is associated with a decline in these cognitive functions. And if you look at the last line, that's the summary of all these cognitive functions together. You can see that it is also on that indicates decline side. So we're seeing strong evidence across multiple studies of this association between hearing loss, worse cognition, and greater risk of dementia. And the next critical question is, what are the mechanistic pathways? So we have this hearing loss dementia association. There could be, first of all, a non-causal mechanism. So this could just be an association we're seeing, and that there's something similar underlying both hearing loss and dementia that's underlying the association we're seeing. It could be like biological aging. It could be a common neuropathologic process. So this is the difference between correlation and causation. We could just see a correlation, but it actually not be a causal relationship. I will say in all these studies that are included in these reviews, they do account for these non-causal mechanisms. So we are pretty confident that there is some relationship here. It's not just related to something underlying, but it is possible. The first causal mechanism that hearing could be related to dementia is through cognitive load. And cognitive load is also called the information degradation hypothesis. So with hearing loss, and in the presence of hearing loss, speech is heard as garbled, which actually requires what's called effortful listening by the brain. So which requires the brain to shift cognitive resources from everything else it's doing, whether it's memory or executive function or attention, and really shift it to being able to hear and process and understand the speech and sound that's coming through. So really, these greater cognitive resources are allocated to auditory processing, which takes cognitive resources away from other parts of the brain to do other cognitive tasks. And we actually see that in MRI studies. So we see that poor hearing is associated with reduced language-driven activity in the primary auditory pathways, but increased compensatory language-driven activity in the prefrontal cortical areas. And this actually can leave the brain a little more vulnerable to neuropathology and dementia. The second potential causal mechanism pathway is the direct pathway of structural changes to the brain. So in animals, we see that hearing loss is associated with reorganization of the auditory cortex. So this is on actually in the brain level, as well as volume changes in central neuronal structures. And in humans, we see their hearing loss is associated with accelerated atrophy in the temporal lobe over 7 years. That's one of the studies we've seen. And the temporal lobe is where a lot of that auditory processing takes place. We also see hearing loss is associated with accelerated late life volume atrophy in the temporal lobe and hippocampus in another study. And this is really the concept of those parts of the brain. So with hearing loss, those parts of the brain that are usually stimulated by hearing are actually understimulated or no longer stimulated. And with the brain, it's kind of like a muscle. It's a use it or lose it function. So if there's less stimulation, then those parts of the brain will just eventually atrophy and will decrease in volume as well, which is another, vulnerability to dementia and neuropathology. And this really gets at a multi-hit theoretical model. So in the brain, there's already some risk to the integrity of the brain. So there's microvascular disease, which just occurs with aging. There could be a separate Alzheimer's neuropathology. And then when you add on hearing loss, it really just adds another hit to the brain that could put the brain over the threshold of vulnerability. And could lead to cognitive decline and dementia. The third pathway is probably the most intuitive, and this is through some of the social and behavioral changes that come with hearing loss. So primarily social isolation, but also loneliness and depression and other mental health concerns. This is the abstract from a literature or systematic review done out of our group. And they actually found not too many studies actually on hearing loss and isolation and loneliness. This was a couple of years ago, so there actually have been a couple more since then. But they did find consistency across those studies. So they did find consistency that there is an association between hearing loss and greater loneliness and greater social isolation. This is something you may see just anecdotally, but this occurs through factors like difficulty with communication, difficulty with physical activity, or being able to get out to do the activities that someone would like, depression, strains on relationships, relationship strain, or marital strain, as well as differences in social support. And if we think back to that figure from the Lancet, social isolation actually does pop up as another of the 12 modifiable risk factors for dementia. It shows up as a late life risk factor and has a population attributable fraction of 4%. So not as high as the 8% of hearing loss, but it's also a pretty strong risk factor and quite modifiable as well. A study we did published in the Journal of the American Geriatric Study found that social isolation was associated with a 28% higher risk of dementia over 9 years. And there's a couple reasons why social isolation is related to dementia. It could be the health behavior pathway of people who are more socially isolated tend to engage in less healthy health behaviors, so like smoking or worse diet or less exercise. It could be the psychological pathway, but through like self-esteem, self-efficacy, sense of well-being. There's also a physiologic pathway in that social isolation affects the body on a molecular level. You see increases in cortisol, upregulation of pro-inflammatory genes, increased inflammation. So there is actually a biologic, physiologic pathway as well. And that leads me to our second poll question.
Okay, everyone. Another true false. Social isolation is not a modifiable risk factor for dementia. Is that true or false? Go ahead and weigh in quickly. Submit your answer. Once again, if you're unable to submit it, please place it in the chat box so you get credit for your CE. Social isolation is not a modifiable risk factor for dementia. True or false? Let's go ahead and take a look at our results. All right, everybody did really great on this one too. Thank you, and back to you, Dr. Wang.
Great. And the third public health question we can look at is what interventions can modify the mechanistic pathways to reduce risk of dementia? So if we think about these three causal mechanisms, hearing loss intervention could reduce the cognitive load of processing degraded sound, could provide increased brain stimulation by restoring that sound and that hearing that goes to the brain, could also improve social engagement. So hearing intervention could intervene on these causal mechanisms to possibly reduce risk of dementia, slow cognitive decline. So the big question, and I would say this is maybe like $1 million billion question, is can treating hearing loss reduce cognitive decline and dementia? Until recently, until this trial, we've only had observational studies that look at this question. And we see from observational studies that there is a suggestion of a benefit of hearing aid use and lower hazards of cognitive decline and dementia. But observational studies are limited. And when I say observational studies, these are like big studies, like if you've heard of NHANES, like the National Health and Nutrition Examination Survey, that follow people across time. They're not randomized, or they're not, given a treatment or a control, like a randomized control trial. They're kind of just observed across time as they, live the lives. So this question really can't be answered through looking at the data from these studies, because there's bias from residual confounding, meaning that in a specific instance, owning and using a hearing aid is very related to socioeconomic status. Hearing aids are expensive. It's about, on average, $5,000 a pair. So really not everyone that needs hearing aids has hearing aids for that reason. It also requires having healthcare access, because until relatively recently, you could only get hearing aids through a clinician, for example, an audiologist. In the past year, hearing aids have been made over the counter, and we're seeing this early rollout of over the counter hearing aids now, which is something this group has also worked to get through Congress. And that's helped with the accessibility. The price is still a little high, so I think there's some work to be done there. But they are more accessible, but really until the past year or so, hearing aids were only available through a clinician. So you had to have healthcare access, you had to have access or transportation to get to a clinician. They were expensive. So you also had to have the funds to be able to buy them. And you also had to, have kind of a priority of health in mind. So all of these factors are actually factors that could reduce your risk for dementia. So it was really hard to tell in these studies whether that benefit of the hearing aids that we were seeing was due to the device itself or due to some of these other factors associated with owning a hearing aid. So randomized trials actually were very much needed to give a definitive answer to this question. And that leads me to the ACHIEVE trial. So this is the Aging and Cognitive Health Evaluation in Elder study. This was a landmark randomized control trial to determine how hearing intervention affects brain health in older adults. This is led by co-investigators, Drs. Franklin and Joseph Koresh, and funded by the National Institute of Aging. And the main focus, the main outcome of this trial was cognitive decline. And that was the primary outcome, was they wanted to know whether hearing intervention could effectively slow cognitive decline. But the study also had some other interests in other areas of health. For example, brain structure, mental health well-being, physical function, and healthcare use. And these are areas that the team is working on right now to look at this data to assess. The results from this trial were published in The Lancet last July, so you can always go there if you would like to see the full study, the full results there. But I'll go over the results quickly here. So the study design, so ACHIEVE participants were recruited from 2 study populations, and really just remember that fact in mind because it comes into play for interpreting the results. So 1/4 of participants came from the atherosclerosis risk and community study. This is a study that's been ongoing. It's observational. Participants were recruited in the 80s in midlife. and followed 30 plus years until now. So they've been involved in research for a while, since they were in midlife. The other 3/4 are new community volunteers. These are people new to research, have not been involved in the study before. These are people that just were interested in the trial and want to sign up. Together, they make up 977 participants. They were 70 to 84 years old, had untreated hearing loss, and were without substantial cognitive impairment. They were split, randomized to hearing intervention or a health education control. The hearing intervention was 4 weeks. They had counseling with an audiologist, as well as fitting of a hearing aid and related technology. And the health education control, also 4 weeks with a health educator. And it was health education topics like nutrition and physical activity. They were followed by the study for every 6 months for 3 years, with final 3-year outcomes of cognitive decline and other health outcomes of interest. So over 3 years, we saw that hearing intervention participants actually consistently used their hearing aids. Over 6 months, the median was 10 hours, and there was a little bit of decrease over the 3 years, but the use was very high. We had about 7-8 hours across the 3 years. So we actually see that they use the hearing aids, which actually might be an indication of how they would rate it as well. And they actually did rate it very high. So nearly all participants said that having the hearing aid changed their enjoyment of life for the better. And almost all participants said that the hearing aid was worth the trouble. So one of the first outcomes we looked at was hearing handicap, and this is a measure of hearing-related quality of life. It includes like communication function, whether hearing limits your participation in activities, whether hearing limits, how confident you are in meeting new people, things like that. And on the y-axis here is the score of this hearing handicap score. And here a higher score means worse. So higher score is bad. And on the x-axis is the follow-up time. And we have health education in blue, hearing intervention in red. And we actually see in the health education control, they stay pretty even maybe go up a little bit by year 3. And you can see if you just focus on the rectangle block, that's where the majority of the participants fall. But then in the hearing intervention, you can see from baseline in gray, there's that really steep drop. They even go from this like mild level, which is this middle block, to having no hearing handicap. They change categories here. And that drop is actually maintained over time. So we can already just see easily that hearing intervention has had an impact on hearing-related quality of life. This is a nice infographic that summarizes the main results. So if we look inside this box here, we see that hearing intervention over 3 years improved communication function. So that's measured by what we just saw, the hearing handicap. We also see that hearing intervention reduced loneliness and social isolation. And we see that actually hearing intervention was effective for maintaining one more person in someone's social network over 3 years. We also see that hearing intervention reduced brain atrophy. So we see it on the MRIs that actually at the brain level, we're seeing a slower atrophy of almost all lobes of the brain. And if we think back to the mechanisms figure, those are the mechanisms that we kind of talked about, was this isolation, loneliness, this brain atrophy. So we can see that hearing intervention, well, this suggests that hearing intervention actually is intervening on these mechanisms. And the main result from the trial is that hearing intervention was associated with a 48% reduction in cognitive decline in some older adults. And I'll add that clarifying phrase in that this was actually only seen in those participants from the ERIC cohort. So those who were already participating in this observational study, they were recruited in midlife. And this looks confusing, but I'll walk you through it. So on the left-hand side is the cognitive functions. We have global cognition, executive function, language and memory, and control and intervention under each. And the second column is 3-year change in that cognitive ability, if we just focus on global cognition for now. And this is a slope, basically. So if you think back to like 7th grade math, the y equals mx plus b, this is the m, so this is the slope. So we're seeing in the control that we're seeing a decline. So we're seeing a decline in global cognition score at the magnitude of a negative 0.402, and this is in standard deviation changes over time. But in the intervention, we're seeing a negative 0.211 slope for 3-year change, which is less steep than the control. So we're seeing that actually both control and intervention, they both have cognitive decline, which is expected with age. This is normal, but that rate of cognitive decline is not as steep in the intervention compared to the control. And the difference between control and intervention, that's what's in the last column, and that's what's plotted on this plot here. So on the right side, it would be favors intervention, which is our difference, favors the intervention here. And we see the same thing actually across the other domains, in that the rate of cognitive decline is slower in the intervention compared to the control. And this is just in the ERIC cohort. When we look at the de novo cohort, we're actually seeing not too much of a difference here, maybe even a little bit on favoring control side. So we actually didn't see a difference in the whole achieved sample, but really this 48% reduction in cognitive decline was restricted to the ERIC cohort. So naturally, the next question is why? And there's a couple, we don't exactly know, but there's a couple of reasons that we think is that the de novo cohort was a healthier population. So they did have fewer risk factors for cognitive decline than the ERIC cohort. For example, they were younger, they had higher education and income, had fewer cognitive chronic conditions. And this is just a matter of how they were recruited. These are 70 to 84-year-old adults that wanted to enroll in a clinical trial. So you can imagine that they're quite healthy, quite health focused. So they're just naturally a little bit healthier. They also had a very slow rate of cognitive decline, and it's really hard to make something slower that's already slow. So we just might not been able to see that effect of hearing intervention in this cohort because their rate of cognitive decline was pretty slow to begin with. So this may represent a healthy volunteer effect in that the ERIC cohort may actually represent or be closer to what we would expect in the general population of older adults. This is something we're still working to figure out, kind of why we're seeing this difference. So if you follow the Achieve study, you'll likely see some more work coming out soon, just kind of getting more at, delineating this difference and why we're seeing it. That leads me to the third poll question.
Okay, true or false? Hearing intervention may slow cognitive decline in some older adults with hearing loss. Again, audience, this is your third poll question. Hearing intervention may slow cognitive decline in some older adults with hearing loss. Is that true or false? Go ahead and quickly submit your answer so that we can go back to Dr. Huang's presentation. Give it a few more seconds and let's go ahead and release those results. Oh, everybody did great again. Very good. Let's go back to you now, Dr. Huang.
Great. I'm going to skip past I added a couple slides on social network characteristics. I'm going to skip past those and we can talk about that in the Q&A if there's interest. Clinical implications of these results. So these are pretty actually really impressive results, I think. the history of, pharmacologic treatments or interventions like this one, there hasn't been really anything that's been found to have quite this magnitude of impact on cognition. Even the pharmacologic treatments that are out there now, effect size is, quite similar to what we're seeing in our trial. But the flip side is that those treatments do come with a lot of risk, and they're a little bit more invasive than, wearing a hearing aid, which is relatively low risk. So this is quite impactful in the dementia cognition world. Hearing interventions are, without substantial risk for most. They do also have other benefits like hearing-related quality of life, isolation, loneliness. They are a late life intervention, and there's not too many of those, and could reduce cognitive decline in some older adults. One thing to remember is that these findings represent the effects at the population level. And I bolded and underlined that because I know it's tempting to, say to a specific person that, this could be what the hearing intervention could have this effect on you. But that's really not what these results say. This effect is not directly applicable to any specific patient. These are population levels. You can't say, with certainty that the person sitting in front of you in the clinic could have a, X% reduction in cognitive decline. And as you can see, it works in some older adults and it doesn't work in others. And that's something we're still trying to figure out. So this is at the population level. I'll also say that this hearing intervention was hearing aids, but as well as the counseling and education. I think that's a really important distinction between, just hearing aids itself. This came with a lot of support and a lot of education. But these results do also support the increased awareness of hearing health and opportunities for treatment. Policy implications. So addressing hearing loss as a strategy for reducing dementia risk supports the ADRD state and federal goals. So this is like the U.S. National Plan to address Alzheimer's disease. We're in Maryland, so this does go along with the Maryland state plan to address ADRD. And I'm sure there could be a similar plan as well in your state. And hearing interventions are, in general, underused, because they're expensive, because they require you to go to a clinician. There's also a stigma attached. So these results really support a policy reevaluation for insurance coverage of hearing aids, for Medicare coverage of hearing aids and hearing care, and an increased need for affordable access. And what's next for Achieve is that we're working really hard. Our team is large and working hard to analyze all this data to determine the effects of hearing intervention on other parts of health. So brain MRI, depression, hospitalizations, physical activity. We're also funded for another 3 years of follow-up. So we have a 6-year follow-up study that's already underway to look at the very long-term effects of hearing intervention on cognition and all these other health outcomes. And I'll close with a few slides on the Know Your Hearing number. So this is a relatively new endeavor for the Cochlear Center for Hearing Public Health. And this is more of a health communications, health education campaign. And it's a campaign to really increase public awareness of hearing health, and to introduce the hearing number as a metric of health, just like you would measure your vision with like 20/20, 20/40. Everyone knows their vision, or just like your blood pressure. Most people don't know their hearing. And most people may not know that there isn't a number that could measure your hearing. So this is really introducing hearing number as like a metric that you could track your health with, just like some of these other metrics we have and use. And for the hearing number, so this is actually the pure tone average that I referred to earlier, and it's something that's used in the clinic, but also in research. Lower means better hearing, actually. So a 0, you could actually be in the negatives as well. That represents really good hearing. and a higher hearing number represents more hearing loss and hearing impairment. So I'm at about 10, I think. But like a teenager could be in 0 or negative, and that's just that natural increase in hearing loss with age. That, like, a kid or a child has really good hearing, but really just as you age, that hearing impairment does kind of set in. And this is a nice picture showing that the frequencies or the parts of the hearing number that are important for different things. So the range of hearing is important for communication. There are also everyday technologies that could benefit the range of hearing. People in certain bands could benefit from OTC hearing aids. Certain bands could benefit from prescription hearing aids, and then the more severe at the higher numbers are more other treatments like cochlear implants. So this metric gives shape to the aspects of health and makes them tangible and neutral. The hearing number introduces a common way to talk about hearing and to really track that change over time. I won't read through all of this, but this is the mission and vision of the Johns Hopkins School of Public Health Hearing Number Initiative. But it's really a campaign to educate people about hearing, and success for this campaign means that, within 2 to 3 years, it's not even needed, that it becomes self-reinforcing, that it's, a common thing, like, what's your vision, that people know about and people know how to use. So in summary, there's a high prevalence of both hearing loss and dementia among older adults, and a strong link between the two. The ACHIEVE study in a randomized control design showed that participants had high adherence to and satisfaction with the hearing intervention. We saw a 48% reduction in the rate of cognitive decline in some older adults, potentially those with more risk factors for cognitive decline. We also saw a beneficial effect for other outcomes like reducing isolation and loneliness. And all of this work together supports an increased awareness of hearing health and policy initiatives to increase affordable access to hearing aids and care. And with that, I'd like to acknowledge the large ACHIEVE study collaborative group. There's a number of people listed here across multiple institutions. You can see across the top. This isn't even everybody listed. The ACHIEVE study was a collaboration between many universities that made this happen. And this is our funding acknowledgements as well. And I would be happy to take questions.
Okay. Oh my gosh. Thank you so much, Dr. Huang, for this valuable and informative topic. So happy that you were able to bring this bring attention to this issue for all of us. And we do have a number of questions. And if others of you are thinking about a question, this is your time to go ahead and enter it into the chat box, and I'll try to include all of those. So while you're doing that, let me just mention a few upcoming CE presentations. On Friday, June 14th, we have World Elder Abuse Awareness Day 2024, and we have a free webinar that offers 1 hour of CE credit. That's Friday, June 14th at 10 a.m. Pacific Standard Time. And then on Tuesday, July 9th at 11:30 Pacific Standard Time, we have Getting Dementia Care Right. That's Tuesday, July 10th. July 9th at 11:30 a.m. And then finally, it gives me great pleasure to say we're bringing David Troxel to our audience, and he's going to talk about our his best friend's approach to dementia care. That's on Wednesday, July 24th at 11 o'clock Pacific Standard Time. And so all of these things are on our calendar. You can look at our education calendar by visiting www.alzoc.org. Okay. And I also want to take just a second to thank our sponsors once again. We couldn't do this without you. O'Connor Mortuary, Care Choices, Hospice and Palliative Services, Caring Companions at Home, and of course, Alzheimer's Orange County. All right. So now let me get to all the questions for our presenter. Okay. So our first question was, so which aspect is the primary factor in dementia? Is it the hearing or the listening processing?
That's a good question. It's all really connected. You can't really have, the listening without the hearing. So I would say I think they're both really important. I think to restore hearing is to kind of restore the whole pathway. So they're both really, connected with the brain and have an impact on cognition and dementia.
Thank you, Dr. Huang. Here's another good question. Is it possible that the higher rate of dementia in patients with hearing loss could include inaccurate diagnoses because patients aren't able to hear and respond to instructions properly?
Yeah, and that's a great point.
Yeah.
Yeah, I think there's a lot of that, especially in clinical care where, people might not be using specific instruments designed for people with hearing loss. In research, we try to do a good job of choosing certain measures of cognition that are, specifically for people with hearing loss. There's those that exist in the Achieve study. We did a screener, almost like a pre-test to make sure that the participants could understand the questions and were able to hear thoroughly to be able to answer the questions, particularly for the cognition part. But in diagnosis in the clinic, I think that definitely could be the case. And I think that's something that in the medical field really needs to be touched on and understood, and that many of these tests and screeners and results and interpretation of results, it's not just a one size fits all. There's differences by like race and ethnicity, there's differences by education level, there's differences for hearing loss status. So I think that's a great point to raise, and definitely a consideration we take in the research.
Thank you, Dr. Huang. The next is a comment. We have an attendee who's been helping her brother with lung cancer and liver disorder, who also had a major stroke in April. And she's noticed that her brother seems to be having hearing issues after the stroke. So I guess she's asking, is there a correlation between stroke and hearing loss?
There could be, for sure. I think it depends on the parts of the brain that are affected.
Thank you. Is it possible that the three-dimensional sound model you presented becomes sparse due to hearing loss, and that degraded sound causes the hearing or the listening to not receive the full sound representation? This then causes a cognitive overload and the sound encoding insufficient such that atrophy occurs due to some signal missing. Should I repeat that?
I think I see it in the chat here.
Okay.
Let me just read it again.
Yes.
Yeah, I think you're on the right track. It's really that with hearing loss, the speech and sound is heard as garbled. So you're not catching all those aspects of the sound that are coming in, and that the brain it causes the brain to really focus on, need to focus on trying to figure out what that sound is and what's coming in. I mean, I think there are ways to kind of mimic the experience. You could probably, imagine, like a cotton ball in your ear or something, and that you can see someone's mouth moving, but are catching bits and pieces here and there. And really you have to focus more on that person and trying to understand what they're saying more than, you could do other things. But I think they're on the right track there.
Thank you. Perhaps the Elon Musk chip implant could be used to process better sound and feed it to the cognitive sound cortex, thereby reducing atrophy and subsequent dementia effects.
Maybe, I don't know. I
I
think
didn't
that's
I didn't know there was an Elon Musk
yeah,
chip
that's
implant.
very, very new. I think it just went into the first patient, not like within the month or 2 months or something. So
Okay.
you know, it's possible.
Okay, thank you. Okay, hi, I'm wondering if Dr. Huang can explain again what global cognition is and what executive function is. And by the way, thank you for bringing this important topic to us.
Yeah, and that's a good clarifying question. So global cognition is just everything. It's executive function, it's memory, it's attention, it's kind of everything combined. Executive function is a component of your total cognition, but it's specifically in the prefrontal cortex. And it's kind of your ability to kind of make decisions, make judgments, to balance more than one thing at one time. It's one of the early things to go, in addition to memory and dementia.
And did you cover executive function too?
Hmm.
Oh, you did. Okay, thank you. I
Yeah.
was reading ahead, so
No,
sorry
you're
about that.
good.
Thank you. Are there gender differences in willingness to have hearing tested and acceptance of hearing
Hmm.
aids?
Um, I would think so. I don't know off the top of my head any kind of like population literature on it. I think anecdotally, I think clinicians may have some experience in seeing like who comes into the clinic more than others. I think it very much deals with stigma of wearing the hearing aid and accepting that there may be something up with the hearing. I think I've heard people say that like getting a hearing aid is kind of like a marker of a life transition or like a stage of life. And there's a lot of work being done to really destigmatize hearing aids. Like right now with the over-the-counter hearing aids, they come in all sorts of shapes and sizes. And with Apple coming out with AirPods and these like Bluetooth headphones, it's like everyone's got something in their ear, whether it's a hearing aid or it's a headphone or something, everyone's always wearing something in their ear. And I think that's been great for the accessibility and inclusion area of really destigmatizing, having something on your ear. But I know for some it's still, it's still a big deal. So I don't know off the top of my head. If I would guess, I would say maybe women are a little more willing to come in and get tested and wear something, but that's an interesting question.
Yeah, probably because they have longer hair and feel like they can hide it more readily. I don't know.
Yeah.
But that's an excellent point about having everybody has something in their ear. So I'm sure that has really helped to destigmatize that.
Hmm.
Um, in addition to the points that were mentioned regarding healthcare disparity and access, are there cultural issues that were studied or that clinicians should be aware of that would be helpful when assisting those impacted by hearing loss?
Um, yeah, I think, let's see. We do a bit of work in other countries in, fitting hearing aids and providing hearing aids. And I think it's more of a cultural approach to health. I think that needs to be taken into account. Maybe not hearing specifically, but just in healthcare and, different ways of taking care of your health. So it's a good point. I'm not entirely sure if there's like a specific answer to that, but I think in general, taking into account, cultural differences in health and how one approaches health is important in this context. I did see one earlier about if Achieve needs volunteers.
Yes.
Yeah, so it's the trial is closed actually. So with the 3-year follow-up, we're just following the same participants for another 6 years. So unfortunately, we're not recruiting for this specific study. But I know are other studies. There's one called Early, EARLHI, I believe, out of Columbia. And right now I can't remember if they are just recruiting in the Manhattan area or if their recruitment is a little broader, but that is another study that's going on that I know of, but I'm sure there's other hearing related studies going on as well.
Thank you. One of our attendees is asking, how do you obtain a hearing number? And I think you gave a link for that, did you not?
Oh, yes, good question. So if you go to this hearingnumber.org, it'll walk you through. There's different ways. There's an app called Mimi. That's the one I used. It's really easy. You download it. You just need a quiet room to do it in because it'll ask you, it'll play a tone at a certain, it's just kind of like the hearing test you did as a kid in gym class. It'll give you a tone at a certain frequency at a certain volume, and it'll ask you to press a button if you can hear it. And it'll do that, a bunch of different times with different tones.
Thank you. Dr. Huang, do you recommend hearing screenings at particular ages, like we do for children, versus waiting for the person to have concerns?
Yeah, I don't think it hurts. I think it's something very different than cognitive screening. So what is it called? The National Task Force. I can't remember it's something task force. It's got a long name, but they actually don't recommend cognitive screening at the moment because sometimes it can do more harm than good. And there's no, like I said, there's no like accessible treatment. There's really no follow-up other than, maybe ways to reduce the symptoms. But for hearing, I think the task force also did not recommend hearing screening, but I could feel a little differently about that, in that, I think it's good to kind of keep track, especially if it's bothering you. I don't think it hurts to, just get at least a baseline of what your hearing is.
Great. Yeah, I did that at age 65, and that was, it was really easy. It was kind of like the one we took in gym class. So I do want to ask for clarification on the first part of your statement, though. You said that you're talking about a group that does not recommend getting cognitive testing.
Yeah, it's the U.S. Preventative Task Force.
Okay.
Yeah, it's a government agency, I believe. And you can look it up, but it's more so about what resources we have to provide.
Okay,
in the background.
because we actually do recommend cognitive
Okay.
testing for adults. And I know that the Alzheimer's Association lobbied successfully for the inclusion of cognitive testing in all wellness exams for older adults. So just a difference of opinion there, I guess. So yeah, let's see. Are there studies underway to evaluate the effect of the recent availability of over-the-counter hearing aids on cognition?
Oh yeah, I'm sure there are. We've been, kicking around some ideas in our group. I'm sure there's studies already underway. I think if you do a simple Google Scholar search, you could likely find some early studies on these over-the-counter hearing aids.
Great. Let's see. Dr. Huang, could a hearing aid help with hearing loss when can you see this one?
Yeah,
it says eustachian tube does not open due to weakened palate. That's a very technical question. Do you?
Yeah, that's a more of a clinical question. I'm not a clinician. I'm an epidemiologist, so I don't have the expertise to really give that kind of clinical advice.
Okay. Thank you. And I'm sorry to disappoint our attendee. Um, but we'll move on. Among the five senses, measure, oh, among the five senses measures, hearing loss would be the major impact of dementia or needed combined five senses metrics to be measured to it? I'm not sure I understand that question. Do you see that in the chat box?
Yeah,
Okay.
I'm not sure I understand it either, but it does bring up the topic of multisensory impairment. And we're
Mm-hmm.
actually seeing that people with more than one sensory impairment have an even higher risk of dementia. Um, so like people with hearing and vision or hearing and olfaction, those are the most common sensory impairments. But we are seeing that interaction between multiple sensory impairments.
That makes sense. Thank you. Has there been any studies related to voice quality, pitch of voice, speed of speech, dropping of voice, etc.?
I maybe don't understand. Maybe in context of what? In terms of like what's easier to hear, or I'd maybe need more context for that question.
Yeah, I'll take a stab at it. I think as a gerontologist, when we talk about how to talk to people, how to speak with people who have hearing loss,
Mm,
we mentioned the three Ps: pace, pitch, and pronunciation as being sort of essential qualities. So if you do try to lower your voice, that can help. And if you speak slowly and clearly and enunciate, that works well too. And actually, those tips work well for talking to someone with dementia. So, that pace, pitch, and pronunciation has multiple applications. Let's see. Since we know what could be linked to cognitive decline, are there any steps toward curing or slowing down cognitive decline? By the way, thank you. It now makes sense that my grandpa's hearing quickly declined and then he suddenly showed symptoms of dementia. So again, the question is, are there any
yeah,
steps toward a cure or slowing down decline?
I think it's a topic that everyone's interested in. The government has it as a large priority of looking for interventions for dementia. I don't think anyone's found this kind of magic treatment or magic cure yet.
Right.
Um, I think it's so difficult because unlike infectious disease, dementia really comes from so many factors. You saw those 12 risk factors across the life course, and that's maybe not, they may be more factors to consider. So from my perspective, I think it's really more of a multi-prong approach of, tackling risk factors concurrently. The only intervention that's shown actually some like significant promise for dementia, it's called the finger intervention. It's a multi-pronged intervention that combines like diet and physical activity and cognitive training, like multiple areas of health, just getting at all of these different risk factors. Um, so I think, if we're thinking about like, oh, what can I do to reduce my risk of dementia? I think it's more so about living a healthy lifestyle, and in all sorts of ways, versus, targeting just one thing. So I don't think, making sure you're wearing a hearing aid if you need it is going to, remove your risk for dementia. I think it's, hearing plus, making sure you're socially engaged and that you're eating a good diet and that some other health like your hypertension is in check, things like that. So I think that's the hope though, is that we find some kind of like magic cure, but right now I don't think we have that yet.
Yeah, I agree. Most experts agree now that we are closer to discovering how to prevent the disease and how to cure it. And those lifestyle factors that Dr. Huang is talking about are, should be top of mind for all of us. And I want to really underscore exercise in those lifestyle factors, but diet and social engagement, all those things that you were talking about, Dr. Huang. So thank you. Let's see. I have sensory neural hearing loss, and most hearing aids do not help me with understanding many words that sound similar. How can we get more research on improvement in this type of hearing loss?
Um, a lot of that I think is in some of the hearing literature as well, like specific types of hearing loss. Um, but I think, the type of hearing loss we deal with is more of that age-related hearing loss. And I think a lot of the clinical research, though, focuses on, some specific types of hearing loss. You might look there.
Okay. Okay. I think we have time for one more question. We are running over time a little bit, so we understand if people need to leave, and we thank you, Dr. Huang, for staying on. Um, let's see. Are there discussions about education related to reducing potential hearing loss, such as using ear protection, reducing use of earbuds that may be negatively impacting your hearing, etc.? So education regarding um, reduction of hearing loss or
Yeah,
things we can do in advance.
there's a lot of that literature out there. I think, reducing noise exposure, I think, is the main thing of, wearing earbuds or earplugs if you're going somewhere loud, like a concert, or if you're doing yard work with a lawnmower. I have a colleague that wears earplugs while she vacuums. And being mindful of how loud your music is if you use headphones for that. So I think, yeah, the main thing is the noise exposure part. And some of that is unavoidable if you work an occupation that has a lot of noise exposure, but I think it's more of that harm reduction of, wearing the ear protection that you can just reduce your exposure to that.
Thank you. Okay, I think that we need to end our webinar at this point. We've gone over by 10 minutes, and we thank you again for that extra time, Dr. Huang. And we thank you just overall for this very valuable topic and for sharing your time and expertise with us. Everyone, please watch for the survey that will open up automatically as you exit the webinar. And again, visit our website at www.alzoc.org for more information about upcoming educational opportunities. Thank you all and have a great day.
Thank you.